Goodpasteur syndrome. Goodpasteur syndrome is not commonly asked only once, but still I'll cover that. What is Goodpasteur syndrome? I explained you in morning that there are three kinds of acute glomerulonephritis. That is acute proliferative glomerulonephritis, rapidly progressive glomerulonephritis, and chronic glomerulonephritis leading on to CKD. So one of the cause of rapidly progressive glomerulonephritis is Goodpasteur syndrome. Let's see what it is. Goodpasteur syndrome is a syndrome characterized by production of antibodies against a alpha 3 chain of collagen, type 4 collagen. It is a disease where both kidney and lungs are involved. I'll start from scratch. First, we'll see the basic overview. In antibodies against alpha 3 chain of T4 collagen, that is type 4 collagen, we have two kinds of disease. These alpha 3 type 4 collagen are abundantly present in kidney as well as in liver. If both the organs are involved, which is most commonly seen in young individuals, it is called as Goodpasteur syndrome or Goodpasteur's disease. If it occurs in old and only renal manifestation is seen, it is called as renal isolated renal disease with antibodies against alpha 3 T4 type 4 collagen. Now we are seeing Goodpasteur disease or syndrome where both kidney and, I mentioned liver here, sorry, not liver, it's lungs, sorry for my mistake. This type 4 collagen alpha 3 chain is abundantly present in lungs and kidney. If both the manifestations are present, it's called as Goodpasteur disease. What is the etiopathogenesis of this disease? We have first trigger and second trigger. Many in diseases like retinoblastoma, which is seen in ophthal, which will be studied in ophthal, and other disease, we have first trigger, second trigger, and all. Likewise here, the first trigger is production of antibodies against non-collagenous domain of alpha 3 chain of type 4 collagen. It is seen most commonly in HLA association, that is DR high risk HLA association are HLA DR2, DR4, and HLA 15. Low risk association are DR1 and DR7. You can remember these things. The first trigger is production of antibodies against this non-collagenous domain of alpha 3 chain of type 4 collagen, which is seen in predisposed individuals with HLA DR2 who are high risk, DR1 who are low risk. Now, what is the second trigger? The second trigger results in clinical manifestations. The second trigger is smoking, hydrocarbons exposure, fluid overload, and pulmonary infections. This is the second trigger where the clinical manifestations are seen. Now, etiopathogenesis, we have first trigger, second trigger. First trigger is production of antibodies. On top of it, if the patient has these following second triggers, he will develop clinical manifestations. The clinical manifestations are pulmonary manifestation and renal manifestations. Pulmonary manifestations are patients present with hemoptysis and cough without fever. This is due to diffuse alveolar hemorrhage. Diffuse alveolar hemorrhage obviously will lead on to hemoptysis and associated with it cough. And characteristic to note that fever is not associated with this kind of cough and hemoptysis, which helps you in differentiating it from other diseases. This is pulmonary manifestation. The renal manifestation, as I already told, is of RPGN, rapidly progressive glomerulonephritis. That is rapidly progressive glomerulonephritis leading on to hematuria, and then hypertension and other things which we saw in glomerulonephritis. Mild proteinuria, mild edema, all those things. These are the pulmonary and renal manifestations of Goodpasteur syndrome. We saw etiopathogenesis and clinical manifestations. Let's proceed for investigations and treatment. What are the investigations that should be done in Goodpasteur syndrome? As usual in as of other disease, we'll do urine routine examination where we can see RBCs in urine. We'll see mild proteinuria. The same things, all things are same. When we do RFT, renal function test, it will be severely impaired compared to acute proliferative glomerulonephritis. We already touched on this point in morning session. Renal function test will be severely impaired than acute one in rapidly progressive glomerulonephritis. And also we see the changes in renal biopsy, the proliferative changes, the crescent formation, increased cell numbers, all those things. Under investigations, you can mention urine routine examination, proteinuria, RBCs, severe impairment of RFT, and you can mention all those things which are tested in RFT. I am sure that all of us know this. And then followed by renal biopsy, which shows the cellular hyperplasia and crescent formation. Now, what is the treatment of this disease? Treatment of this disease is, since it's due to production of antibodies as a primary trigger, we can do PLEX, that is plasma exchange. Along with plasma exchange, we can immunosuppress the patient with steroids and cyclophosphamide. And we consider renal transplant in the patients after 6 months of antibodies negativity. That's it. About this is all about Goodpasteur disease. The Goodpasteur disease, we saw etiopathogenesis. The first trigger, second trigger. First trigger is production of antibody. Second trigger is maybe pulmonary infection, smoking, fluid overload, hydrocarbon exposure. Under clinical manifestations, we saw pulmonary manifestation and renal manifestation, diffuse alveolar hemorrhage, and this hematuria, hypertension, rapidly progressive glomerulonephritis manifestation. And then under investigations, we saw urine routine, RFT, renal biopsy, followed by treatment, that is PLEX, that is plasma exchange, and steroid cyclophosphamide. And then renal transplant after 6 months of antibodies being negative. This is all about Goodpasteur syndrome. Next topic for discussion is renovascular hypertension. Please don't get confused by this term, renovascular hypertension. Renovascular hypertension is other name for renal artery stenosis, RAS. What is renal artery stenosis? The term is self-explanatory. The renal artery is stenosed. We'll see in brief about renal artery stenosis now. First, let's start with etiopathogenesis. What is the etiology of this condition, that is renal artery stenosis? Why the vessel can get narrowed? Vessel can get narrowed because of something blocking from inside, or the vessel may become thick and secondary leading to blockage, or some external agent may press on and cause compression. The most common cause of renal artery stenosis is atherosclerosis, as in case with coronary artery disease, stroke, and all. Other important cause of renal artery stenosis in young patients, in non-Indians, not commonly seen in Indians, is fibromuscular dysplasia. The term tells there is fibromuscular dysplasia that is surrounding the blood vessel. And the other important cause of renal artery stenosis is vasculitis. Right? Vasculitis, the Takayasu arteritis is one of the important cause of renal artery stenosis in young in India. Takayasu arteritis, and also we have polyarteritis nodosa. What are these terms? We will see when we discuss rheumatology. These are the three important causes of renal artery stenosis, that is atherosclerosis most common, followed by fibromuscular dysplasia in young patients in non-Indians, and also vasculitis, Takayasu, and polyarteritis nodosa in vasculitis associated renal artery stenosis. The Takayasu arteritis is most common in females than men, the 9:1 ratio. We'll see all those things afterwards. This is about etiology of renal artery stenosis. The pathophysiology is very interesting in renal artery stenosis. The pathophysiology, we have two kinds. Basically, we have two kinds of renal artery stenosis, that is unilateral and bilateral. We all know this. First, we'll see pathophysiology of unilateral renal artery stenosis followed by bilateral renal artery stenosis. The unilateral renal artery stenosis pathophysiology is explained by Goldblatt 2 kidney 1 clip hypothesis. You need not remember this name. What happens in unilateral renal artery stenosis? We know one kidney is affected in unilateral side, the other kidney will be normal. First, I'll talk about affected kidney. In the affected kidney, when the blood vessel is compressed, that is narrowed, there will be reduced blood supply, leading to reduced GFR. This reduced GFR, reduced blood supply, will lead to reduced GFR. What happens when GFR is reduced? In the first day, when I explained deeply about nephrotic and nephritic syndrome, I gone through tubular glomerular feedback, but I'll explain it for you once again. When GFR is decreased, due to three mechanisms, it can activate RAS. One of the mechanisms which applies here is the myogenic response. The afferent arteriole is surrounded by muscles, smooth muscles. These smooth muscles are like pressure sensitive smooth muscles. When the pressure is reduced, these get stimulated and stimulates the JG apparatus, juxtaglomerular apparatus, to activate a RAS system, renin angiotensin aldosterone system. So due to reduced blood supply, there will be reduced GFR, leading on to reduced GFR, leading on to myogenic response, which leads to activation of RAS system. The activation of renin angiotensin aldosterone system will lead on to hypertension crisis. Why? Why does activation of RAS lead on to hypertension crisis? There is increased aldosterone. There is increased aldosterone, and also there is increased angiotensin 2. We have two great players here. One is increased aldosterone will stimulate ENaC channels and cause sodium water retention, leading on to hypertension. The second one, the angiotensin 2, will go and stimulate angiotensin 2 receptors and cause vasoconstriction, leading on to hypertension. These two players will lead on to hypertensive crisis in unilateral RAS. So there is activation RAS leading on to hypertensive crisis. This is the story of affected kidney. What about the normal kidney? The normal kidney is the king here, the savior. I will call it the savior. Because when his fellow gets affected, else I will compensate for you. The normal kidney undergoes pressure natriuresis. When the other kidney blood supply is reduced, it is followed by increased GFR in the opposite kidney, and thereby increased GFR leading on to increased filtration and pressure natriuresis. So this is the savior which saves us, which saves the patient from developing flash pulmonary edema by pressure natriuresis. I hope you understood this. The normal kidney, increased GFR, increased filtration, which causes pressure natriuresis, and thereby saving the patient, preventing the patient from going into flash pulmonary edema. So I'll summarize once the unilateral RAS pathophysiology. The affected kidney, reduced blood supply, reduced GFR leading on to RAS activation and hypertensive crisis. and the normal kidney will undergo pressure natriuresis, saving the patient from preventing the patient from developing flash pulmonary edema. Okay, this is the story of unilateral RAS, that is renin angiotensin system. Let's go on for management. I will finish off the management of unilateral and then I'll proceed with bilateral. Now we saw idiopathogenesis and clinical manifestation of unilateral renal artery stenosis. The clinical manifestation is simple: hypertensive crisis, refractory hypertension. So, in the any patient who is presenting with hypertensive crisis newly onset, please do suspect unilateral renal artery stenosis. Next, go on for management. How to manage this patient? The investigations. On investigation, on USG, we may see asymmetrical kidney, the affected and the normal kidney, there may be asymmetry because the atherosclerosis doesn't occur in one day, it occurs in years. But the manifestation may be acute. So on USG, we may see asymmetrical kidney, and the investigation of choice is CT renal angiography or MR renal angiography. It is quite intuitive because blood vessel is stenosed. We should visualize the blood vessel. How to visualize it? Do CT renal angiography or MR renal angiography. See the stenosed artery, diagnose the condition, treat it, and help the patient. Now, what is the treatment that we offer to these patients? The treatment is most importantly ACE-ARB inhibitors. See, look out. ACE-ARB inhibitors is not contraindicated in unilateral RAS. It is only contraindicated in bilateral. I will tell now when we discuss bilateral one. ACE-ARB inhibitors are given to manage hypertensive crisis. And also, we can do percutaneous transluminal renal angioplasty. Nothing but we'll go to renal artery, take the balloon, inflate it, and make the stenosed artery dilated, that is gain normal vessel caliber and improve the blood supply. Similar to the PDCA that we do in heart patients, that is in case of coronary artery disease. The percutaneous transluminal renal angioplasty PTRA can be only be done if the affected kidney size is more than 8 centimeter, or else it's not so useful. Now we saw renal artery stenosis, etiopathogenesis, etiology, and then we saw unilateral renal artery stenosis. Under unilateral one, we saw pathophysiology, how the affected kidney and renal kidney functions. In the affected kidney, reduced blood supply, reduced GFR, RAS activation leading on to hypertensive crisis. And then the normal kidney, the savior, causing pressure natriuresis, preventing the patient from developing pulmonary edema. And then we saw investigations on USG asymmetric kidney, the investigation of choice CT renal angio or MR renal angiography. The treatment is ACE-ARB inhibitors and adequate management of hypertension. And also we can do PTRA if the affected kidney size is more than 8 centimeter. This is all about unilateral renal artery stenosis. Let's go on for bilateral renal artery stenosis. In the bilateral renal artery stenosis, the name implies that both the renal arteries are stenosed. Now what to do? Both the arteries are stenosed. When both the arteries are stenosed, both sides afferent arterioles will get the signal. Myogenic response. Both sides RAS activation. There will be severe activation of RAS system, renin angiotensin aldosterone system, leading on to development of hypertension. I explained how hypertension previously, and also flash pulmonary edema. So why flash pulmonary edema is not seen in unilateral but seen in bilateral one? I already explained. In unilateral, the savior, normal kidney, will undergo pressure natriuresis and prevents the patient from developing flash pulmonary edema. Whereas if both the kidneys are affected, there is no savior. Both the kidneys are affected now, leading on to acute retention of fluids, water and electrolytes, leading on to flash pulmonary edema. If the patient present with resistant hypertension and flash pulmonary edema, you should think of bilateral renal artery stenosis. Now, how to manage this patient? Investigation is same. It doesn't change. In renal CT renal angio, you will see bilateral renal artery stenosis. That's it. What is the treatment? Treatment, we can't give ACE/ARB inhibitors. Now you will ask me why. Because see how RAS acts. When angiotensin is produced, angiotensin 2 is produced, it will go and act on when angiotensin 2 is produced, it will go and act on efferent arteriole. Efferent arteriole. When the efferent arteriole is compressed, there is more and more filtration here. Efferent arteriole compressed, more and more water filtration, increased GFR. This helps to maintain the GFR when blood supply to the kidney or GFR is reduced due to hypotension or renal artery stenosis, any other cause. It's the same mechanism in all the cases. When there is RAS activation, the angiotensin 2 will go and act on efferent arteriole. It will cause more and more filtration of fluids across the glomerular basement membrane and increases the GFR, thereby maintaining GFR and renal function. So, in this case, both sides the kidney are compromised. When both the kidneys are compromised, if you go angiotensin 2 receptor inhibitors, ARBs or ACE inhibitors, this will reduce the action of angiotensin 2, which is causing efferent arteriolar constriction and thereby maintaining GFR. Now, by giving this blockers, drugs, you are effectively reducing the GFR in a affected kidney, which should not be done. So, due to this reason, the ACE/ARB inhibitors are strictly contraindicated in case of bilateral renal artery stenosis. Then, how do you manage BP, blood pressure? Give diuretics to the patient and manage the blood pressure. It helps in management of blood pressure, as well as flash pulmonary edema. This is all about renal artery stenosis. I will give quick summary of bilateral renal artery stenosis. Etiopathogenesis, etiology we already saw. Pathogenesis, both the kidneys are compromised, leading on to severe activation of RAS system. No pressure natriuresis, the savior is not there. Increased salt and water retention, leading on to flash pulmonary edema. The investigations are same as unilateral renal artery stenosis. The treatment is ACE/ARB inhibitors. Sorry, not ACE/ARB inhibitors. ACE/ARB inhibitors are contraindicated. The BP is managed by giving diuretics, which is the drug of choice. BP control and flash pulmonary edema is treated with diuretics. This completes our topic, renal artery stenosis. Now we finished two topics, Goodpasteur syndrome and renal artery stenosis. Okay. End-stage renal failure common causes. I searched for common causes of end-stage renal failure in our Archit Balo textbook and other textbooks, but I didn't get the causes. So I searched in Notebook LM. Hopefully it has searched from Harrison or other textbook. I'll briefly mention the causes. You can note it down. The causes of common causes of end-stage renal disease are diabetic nephropathy, which is the most common cause of CKD. And then we have some congenital syndromes, inherited syndrome, that is Alport syndrome, inherited tubulointerstitial diseases, complete LCAT deficiency, I don't know what it is, glomerular, vascular, and autoimmune syndromes, atypical HUS, SLE, lupus nephritis, Enosh-Collin purpura, and other causes. I will mention this. End-stage renal disease, common causes, glomerular causes. Glomerular causes, Most commonly we know diabetic nephropathy, then followed by chronic not chronic tubular interstitial disease, glomerular nephropathy, or there can be other glomerular diseases like FSGS, focal segmental glomerulosclerosis, membranous nephropathy, and other causes. Tubulointerstitial causes. Tubulointerstitial causes, we have chronic tubulointerstitial disease. Then tubular cause, we have polycystic kidney disease. We discussed morning that 60% of patients develop CKD by 60 years. Sorry, end stage renal disease by 60 years. And then we have other syndromes like Alport syndrome. Okay, those are the tubular interstitial causes, glomerular causes, and other causes are this we can mention briefly and talk about each causes, three lines, and manage this 5 mark. I think it's asked only once. Yes, but I didn't get the specific answer for it, so I briefly mentioned it. You can manage this question like this. Let's proceed on for next question, that is renal osteodystrophy. Very interesting topic. Renal osteodystrophy. It's the old term. Renal osteodystrophy is the old term. The new term is mineral bone disease. What is renal osteodystrophy or mineral bone disease? The term is self-explanatory. Mineral bone disease. There is mineral abnormality and bone abnormality. What are those? Let's see. The mineral bone disease or renal osteodystrophy is broadly classified into two types: high turnover bone disease, mineral bone disease; low turnover mineral bone disease. Please don't think that low bone turnover has better prognosis because the turnover is low. It is counterintuitive. It has worst prognosis. The bone turnover disease has better prognosis compared to low bone turnover disease. Now, high bone turnover disease, the other name is osteitis fibrosa cystica. The low bone turnover disease, other name is adynamic bone disease. Let's see high bone turnover disease, osteitis fibrosa cystica first, followed by low bone turnover disease. What is the etiopathophysiciology of high bone turnover disease or osteitis fibrosa cystica? It's very interesting. Due to renal impairment, we have increased phosphorus levels, and also other elements, other minerals are increased. Here we are taking phosphorus because it's important in pathophysiology. Increased phosphorus levels will stimulate osteocytes of the bone. Will it do? The osteocytes will secrete FGF23. What is this FGF23? FGF23 is fibroblast growth factor 23. Previously, it was thought that FGF23 is the hero. But with the time, we got to know that it's both hero and villain. Why? Because FGF23 was thought as hero because it increases the phosphorus excretion, so thereby reducing the phosphorus levels and thereby reducing the secondary complication due to increase in phosphorus. We thought it was a hero. In cost of other deadly diseases like left ventricular hypertrophy, not deadly, other serious diseases like left ventricular hypertrophy. And also, it inhibits 1-alpha hydroxylase. What does inhibition of 1-alpha hydroxylase do? We all know that vitamin D activation occurs at 2 stages. That is in liver, followed by kidney. In kidney, 1-alpha hydroxylase is responsible for vitamin D activation. What is the role of vitamin D in calcium homeostasis? The vitamin D increases the calcium reabsorption from the GIT as well as from the renal system. And also it increases the excretion of phosphorus. Now, this FGF23 is inhibiting 1-alpha hydroxylase, leading on to hypocalcemia. Now here the story begins. When there is hypocalcemia, our calcium sensing receptors present in parathyroid cells will get activated. These parathyroid cells will secrete parathormone. The increased parathormone will cause bone reabsorption. This is the important point leading on to clinical manifestations. Increased parathormone levels. We all know that increased parathormone levels will cause bone reabsorption, thereby increasing serum calcium levels and phosphorus levels. When there is repeated bone reabsorption, see, this is the bone. The bone is getting repeatedly reabsorbed, the caveats are formed. Now these parts is replaced by fibrous tissue and cyst, thereby the name osteitis fibrosa cystica. What does these do? Now the healthy, strong bone is replaced by fibrous and cystic spaces. This leads on to pathological fracture, obviously, and also bony tenderness. Also, increased calcium and phosphorus levels will cause medial calcification. We discussed yesterday that medial calcification is one of the causes which makes the patient to be unfit for renal transplantation. This is the major complication. Medial calcification and fractures are the major clinical manifestations seen in osteitis fibrosa cystica, which causes and which makes the patient being unfit for renal transplantation, and fractures are seen. Now I'll summarize pathophysiology once. Increased phosphorus levels stimulating osteocytes to secrete fibroblast growth factor 23, FGS23. When the FGS23, both hero and villain. It's a hero because it increases the excretion of phosphorus, villain because it causes left ventricular hypertrophy and inhibits 1-alpha hydroxylase, which causes hypocalcemia, increased parathormone levels. Increased parathormone levels will cause reabsorption of bone, which causes osteitis fibrosa cystica, and it secondarily increases calcium and phosphorus, leading on for medial calcification, which makes the patient unfit for renal transplantation. Now, what are the clinical manifestations of this? We already mentioned fractures and bony tenderness. Pathological fracture and bony tenderness are the important clinical manifestation of osteitis fibrosa cystica. Now, what is the treatment of this condition? You'll ask me what are the investigation? Investigation, you can estimate serum electrolytes level. You can see increased calcium and phosphorus levels. Along with that, when you estimate parathormone levels, it will be increased. And also you can do X-ray, where we will see the fibrous cystic spaces in bone. From next class, I'll try to include the X-rays of the disease. Now this is the investigation. Investigation, we can do serum electrolytes, increase calcium and phosphorus levels, increase parathormone levels. On X-ray, we see fibrous cystic spaces. This is the investigation. What is the treatment of this condition? The treatment is here, you see here. Increased phosphorus level is the main culprit leading on to all this pathophysiological process. So we give phosphate binders like calcium phosphate and sevelamer carbonate. Calcium, we prefer sevelamer carbonate than calcium carbonate. We can give sevelamer carbonate, which will bind the phosphate inside the blood, reduce its levels and reduce these secondary complications. This is the treatment of high bone turnover disease, osteitis fibrosa cystica. Now, in renal osteodystrophy, we have high bone turnover disease and low bone turnover disease. We finished with high bone turnover disease. Let's go on for low bone turnover disease, which has worst prognosis compared to high bone turnover. The low bone turnover disease, as I already told, is also called adynamic bone disease. Now, what is the etiopathogenesis of this condition? The etiology is, we have risk factor. That is female patient who is obese and diabetic. Female patient who is obese and diabetic are the risk factors for low bone turnover disease. Now, what is the pathophysiological process occurring in the body? The pathophysiological processes are mainly calcification because of increased intake of calcium supplements, which lead on to increased calcium phosphate. The increased calcium phosphate will cause calcification of the vessels, and also increased calcium and phosphate levels. Listen to it carefully. Increased levels of calcium and phosphate level will cause transformation of endothelium into osteoblast. This causes deposition of deposition of calcium and causes medial calcification. This medial calcification will make the patient unfit for renal transplantation. What is the clinical manifestation of this condition? There is calcification all over the body in many sites. Medial calcification we already saw. There can be pulmonary calcifications and then periarticular calcifications. This is about idiopathophysiology and clinical manifestation. On investigation, you can do the X-ray. We will see investigation on X-ray. We can see the periarterial calcifications, calcification occurring in pulmonary system, lungs, and also periarticular calcification, which will be visible on X-ray. The investigation, we usually do X-ray. We can also estimate blood serum levels where calcium level will be increased. What is the treatment of this condition? See here, excess calcium intake is one of the cause. Please stop taking calcium supplements. And also, if the patient has low bone turnover disease, we already know that the patient have CKD, grade 4 or 5 CKD. While doing dialysis, we'll do low dialysis using low calcium dialysate. Remember this point. We use dialysis using low calcium dialysate. I missed to mention one of the important point. While discussing CKD, I mentioned that ABCDE complications. This renal osteodystrophy is one of the complications of CKD. I missed the most important point itself. So this is the complication of CKD, most important complication of CKD, one of the most important complication of CKD. So we can do dialysis. I'll summarize low bone turnover disease, idiopathogenesis, etiology. The risk factors are female patient, obese, and diabetes mellitus, who is taking excessive calcium supplements, leading on for increased calcium phosphate levels, periarterial calcifications, and also conversion of endothelium into osteoblast, and which in turn lays the calcium, which causes calcium deposition around the vessels. Clinical manifestations are periarticular calcification, pulmonary calcification, and periarterial calcification. Treatment is stop taking supplements and do dialysis using low calcium dialysate. That's it about bone mineral disease, which is one of the complications of CKD. So in 5 marks question, we finished another question, that is renal osteodystrophy. Renal replacement therapy. The term is self-explanatory. We are replacing the function of renal system, that is kidney. Now, what are the indications which makes us to choose for renal replacement therapy? The indications for dialysis are hyperkalemia more than 6 millimole per liter, metabolic acidosis not responding for many medical management, that is infusion of sodium bicarbonate. Hyperkalemia and metabolic acidosis are most commonly seen in acute kidney failure, we already saw yesterday. And also fluid overload and pulmonary edema, which is refractory to treatment. We can go on for renal replacement therapy. Fluid overload and pulmonary edema, we saw one of the cause, that is bilateral renal artery stenosis. In case of uremic pericarditis, uremic encephalopathy seen in CKD, we can do dialysis. So dialysis can be done in if the patient has hyperkalemia more than 6 millimole per liter, metabolic acidosis not responding to medical management, fluid overload and pulmonary edema, uremic pericarditis and uremic encephalopathy. These are the indications of renal replacement therapy. Indications are important. Please do remember this. Now, what are the types of renal replacement therapy? We have three types: hemodialysis, peritoneal dialysis, and continuous renal replacement therapy. What is hemodialysis? Hemodialysis is a procedure where the blood is made to, okay, I'll first explain the principle. We have solute concentration which is more, that is urea, potassium, acids level is more inside the blood. We make the blood to be in contact with the solvent which has less concentration of all these electrolytes through the semi-permeable membrane. We know the basics. The solutes move from higher concentration to lower concentration. Due to this concentration gradient, the solutes like urea, potassium, and hydrogen will move from blood to the dialysate, the dialyzing fluid, thereby removing all the toxic substances from the blood, which is the function of kidney. If not functional, we are making the semi-permeable membrane to do the function. So how it is different from peritoneal dialysis? In hemodialysis, we will use artificial semi-permeable membrane. Like we can use cellulose acetate and polycarbonate. Cellulose acetate and polycarbonate. We can use the peritoneal membrane, which is naturally present in all of us, as a semi-permeable membrane, and we can perform dialysis. That is called renal peritoneal dialysis. Peritoneal dialysis is less efficient compared to hemodialysis. Coming to hemodialysis, the principle I already explained. Next, we have procedure. How hemodialysis is done. First, we have to get an access to the blood vessel to draw blood. Those accesses are made by creating arteriovenous fistula in the forearm. We can draw blood from internal jugular vein, and also we can draw blood from femoral vein. In internal and femoral vein, internal jugular vein and femoral vein, we can use catheter and draw blood. In AV fistula also, we will use catheter to draw blood. Now blood is drawn outside the body. Whenever blood is drawn outside the body, it's prone for thrombosis. It can coagulate. So we'll infuse an anticoagulant, that is heparin, into the blood. Now this heparinized blood is made to pass through the dialyzing machine, where semi-permeable membrane is present. Now all the solutes which have higher concentration will move from the position of higher concentration to lower concentration. Thereby urea, creatinine, and potassium, hydrogen are removed from the blood. And then again, the now work is done. Afterwards, we'll reinfuse the blood into the patient body. This is the procedure of hemodialysis. What are the complications of hemodialysis? Now, we have added heparin. It can cause hemorrhage. Because we are removing solutes and water from the blood in the dialyzing machine, we can get hypotension. And also, due to faulty technique, there may be air embolism. We are using dialyzing fluid where the solute concentration is less. Some patients may be allergic to this dialyzing fluid, some constituency in this dialyzing fluid, leading on for allergic reactions. These are all the complications related to procedure. And also, other important complication is due to rapid decrease in plasma osmolarity. What is plasma osmolarity? Why it is decreased rapidly? Because the solutes are being removed from blood into the dialyzing fluid to the semi-permeable membrane. When the plasma osmolarity is decreased rapidly, it leads on to dialysis disequilibrium syndrome. We just need to remember the name of this. This has not been asked in exams. And also the long term with time, continued dialysis may lead on to dementia. These are all the procedure, complications, and principle of hemodialysis. We saw under renal replacement therapy, we have three types: hemodialysis, peritoneal dialysis, continuous renal replacement therapy. In renal hemodialysis, we saw principle: movement from higher concentration to lower concentration. The procedure, we saw draw blood, make it pass through dialyzing machine, and reinfuse the blood. The complications, we saw hypotension, hemorrhage, air embolism, allergy, and dialysis disequilibrium syndrome, where cerebral edema is seen. And also, with time, the patient will develop dementia, dialysis associated dementia. Now, this is all about hemodialysis. Let's go for peritoneal dialysis. In the peritoneal dialysis, the principle is same. The constitutes, the solutes move from a region of higher concentration to lower concentration, but here semi-permeable membrane is our own peritoneal membrane, the patient's own peritoneal membrane. What is the procedure? Now, we will infuse dextrose solution up to 1.5 to 3 liter into the peritoneal cavity of the patient. This solution is deficient in solutes, which are this. Let's make it as peritoneal membrane. Now, this is the dextrose fluid which we have infused, and let's assume here are the blood vessels in the peritoneal cavity. Now, here in the dextrose solution, the concentration is low, the solute concentration is low. Here the solute concentration is high, so the solutes will move from region of higher and to lower, thereby removing all these toxic substances, urea, creatinine, potassium, and hydrogen. Thereby our work is done. So this dextrose solution, we make it to stay for 2 to 4 hours. After that, we'll remove the solution. So thereby we have reduced the solute concentration inside the blood. So this is about the peritoneal dialysis. And what are the complications seen in peritoneal dialysis? We can have peritonitis because we are meddling with peritoneum in the process. While infusing or doing some procedure, we can introduce infectious material and cause peritonitis. And also, because we are giving dextrose, we can the patient may have hyperglycemia, and with repeated peritoneal dialysis, the patient may have weight gain due to hyperglycemia. And also, the patient can have protein malnutrition due to loss of protein in the dialyzing fluid. Not dialyzing fluid, in the dextrose solution nutrition. This is about procedure and complications of peritoneal dialysis. Under renal replacement therapy, we finished hemodialysis and peritoneal dialysis. The peritoneal dialysis, we infused dextrose 1 to 1.5 to 3 liters into the peritoneal cavity, so that the solutes from blood move into this solution. After 2 to 4 hours, we'll remove this solution, thereby reducing the solute concentration. The complications, we saw peritonitis, hyperglycemia, weight gain, and protein malnutrition. Now, another renal replacement therapy type is continuous renal replacement therapy, where this peritoneal and hemodialysis will go on for a few hours. Let's take 4 to 5 hours. But in continual renal replacement therapy, the dialysis is done for all 24 hours. Why it is done? Because in the patient who are unstable, who have hypotension, we can't afford to do the fluctuations in plasma solute and water level quickly, which is done in case of peritoneal and hemodialysis. So we do gentle dialysis. That is, we do dialysis slowly over time. That is the use of continuous renal replacement therapy. In continuous renal replacement therapy is used in case of unstable patients with hypotension, where we do gentle dialysis for 24 hours. This is all about renal replacement therapy. We saw indications, and then hemodialysis, peritoneal dialysis, and continuous renal replacement therapy. Urinary tract infection. It's the infection occurring anywhere from kidneys to the urethra. The definition: urine culture, if there is more than 10 to the power of 5 colony forming units per ml in the midstream urine, it is called as UTI, urinary tract infection. It can be upper urinary tract infection or lower urinary tract infection. Upper urinary tract infection includes the kidney up to this point, that is up to pelvis. And lower urinary tract infection include the bladder and structures below it. So under upper urinary tract infection, we have pyelonephritis and perinephric abscess. Acute pyelonephritis, we discussed it extensively yesterday. And then under lower urinary tract infections, we have cystitis, prostatitis, and urethritis. Let's discuss what is the clinical manifestation in brief. Clinical manifestation is, before going to clinical manifestation, we should see etiopathogenesis. So UTI, we saw the definition and the types, upper and lower anatomical classification. Let's go on for etiopathogenesis. What are the organisms causing urinary tract infection? In immunocompetent individuals, E. coli is the most common cause of UTI in 85% of them. In remaining patients, Proteus, the Klebsiella, Enterococcus, and other organisms can cause UTI. In immunocompetent one, these are common, E. coli and these bacteria. In immunosuppressed patients, the viruses like adenovirus and cytomegalovirus infection is pretty common. Now, how do these organisms reach the site, urinary tract? Most commonly, they reach by ascending route. We discussed while discussing acute pyelonephritis. There's obstruction anywhere between renal pelvis to the urethra due to prostatic enlargement, any malignancies, the renal stones, or due to vesicourethral reflex and pyloric dilatation seen in children. Not pyloric. The renal pelvis dilatation seen in children, and many other causes due to obstruction, and all these causes, there can be ascending infection from here to the kidney, leading on to acute pyelonephritis or perinephric abscess. Perinephric abscess can also be caused by spread of infection from adjacent structures. And also less common cause is hematogenous spread. The infection anywhere in the body can reach the urinary tract through blood and cause infection. So we saw etiopathogenesis, the causative organisms and routes, that is ascending and hematogenous spread. And also we have spread from surrounding tissue. Now, what are the clinical manifestations? Most of the patients are asymptomatic. They have asymptomatic bacteriuria in pregnancy and other things. In asymptomatic patients, in females, until and unless they are pregnant, we don't treat. If the patient are symptomatic, according to the disease, they have manifestation. If the patient has acute pyelonephritis, they will have triad of symptoms, that is loin pain, fever, and renal angle tenderness. If the patient has perinephric abscess, they will have pain, loin pain, and they will be running with severe grade fever. And if the patient has cystitis, there will be hematuria, the lower suprapubic pain, and also fever. In case of prostatitis, same suprapubic pain, fever, and urethritis. Also, the patient may have pus discharging from urethra. You will have dysuria, all these things. These are all the clinical manifestations in case of UTI. Now, what is the treatment of UTI? Before that, let's see the investigations. Investigations, we'll do the routine ones on urine examination, urine routine examination. We'll see excretion of WBCs in urine more than 5. Also, we may see the this is the on the urine routine examination. On urine culture, we'll get the organism that is more than 10 to the power of 5 per ml. And also, we'll do culture sensitivity to detect antibiotic sensitivity. The specific investigations are in pyelonephritis, we can do CT, and also in perinephric acid, we can do CT examination. And in cases of, we can also do intravenous urogram in case of this one, where in acute pyelonephritis, we can do cystoscopy, urography, and other things. Urinary biomarkers like N-acetyl beta-D glucosaminidase and KIM1 can be used as early indicator of renal injury. If you want, you can remember this point. So this is about investigation seen in UTI. That is investigations of UTI, the routine one and special one. The routine one are urine routine examination, where we see WBC is more than 5, urine culture more than 5 per ml, in the power of 5 per ml organisms. And also the special investigation, we can do intravenous urogram, CT scan of kidney, ultrasound of kidney, and you can do urinary biomarkers. Now, how to treat these patients? Cotrimoxazole is most commonly used drug. We can also use ampicillin, amoxicillin. Ampicillin and amoxicillin are given as 250 mg 3 times a day. And also, we should advise the patient to drink more than 2 liters of water per day. If the patient has severe disease and hospitalized, we can give IV antibiotics like IV ceftriaxone. Or if the patient is not responding for IV ceftriaxone, we can give piperacillin tazobactam to the patient. This is about UTI. Upper urinary tract infection, if the question comes, you can mention all about acute pyelonephritis and few points about perinephric abscess. If the lower urinary tract infection is the question, taking this as background, you can elaborate on cystitis, prostatitis, and urethritis. And also about recurrent urinary tract infection, which is mostly important in children. Recurrent urinary tract infection, it is mostly seen in children. It is a pediatric question, so we can discuss this while discussing UTI under pediatric nephrology. By this, we will complete all the 5-mark questions. Now we are left with only 3-mark questions. So let's see the 3 markers. Chronic, we have hemorrhage, and we have vomiting. GIT causes vomiting, diarrhea, and other condition. And also drug induced renal dysfunction we can also reverse. We know that drugs like cisplatin, vancomycin, this will cause acute tubular necrosis. So to summarize, the reversible causes of CKD are 3 things we'll mention, that is hemorrhage, and then GIT loss by diarrhea and vomiting. Also, we can mention drugs like drug intake like cisplatin and aminoglycosides. Okay, this is the first question. The second question, urinary cast. I'll explain it briefly. We have RBC cast in case of glomerulonephritis, WBC cast seen in acute tubular necrosis, acute tubulointerstitial disease, and also we have hyaline cast seen in CKD. We have fatty cast seen in nephrotic syndrome. Please study about renal cast more deeply. These are in brief. Benzoin proteinuria, we saw multiple myeloma, chronic lymphoid leukemia, and amyloidosis. Discuss three causes of proteinuria, three types of proteinuria. The transient proteinuria. The transient proteinuria, the question is self-explanatory. It's seen only transiently. It's seen in heavy exercise, albumin infusion. Albumin infusion because the protein is being infused, so there is increased excretion. So transient proteinuria. What is orthostatic proteinuria? Orthostatic proteinuria. Usually seen in 2 to 5% of adolescents, and it's rare after the age of 30 years. And also, because it's not given here, 2 to 5% of adolescents, it's commonly seen, it's mentioned in textbook. Okay, let it be. Then we have overflow proteinuria. Overflow proteinuria because the concentration of these particular proteins in plasma is increased very much. So they are being excreted in urine. We have hemoglobinuria, myoglobinuria, and the Benz-Jones proteins excretion in multiple myeloma. Also, we have glomerular proteinuria. We all know this glomerular proteinuria, seen in acute proliferative glomerulonephritis, rapidly progressive glomerulonephritis, the acute proliferating, we know post-streptococcal glomerulonephritis, and then we know in RPGN Goodpasteur syndrome, RPG, and also we have post-infectious glomerulonephritis, and many other causes are there. So this is enough, I think. Under proteinuria, the examiner has 3 types. Let's mention 4 types. Also, other one I try to mention. Tubulointerstitial proteinuria. Due to the disease of tubulointerstitium, the proteinuria is seen. The tubulointerstitial proteinuria are heavy metal intoxication causing it, heavy metals intoxication, and autoimmune conditions causing tubulointerstitial disease, leading on to tubulointerstitial proteinuria. Proteinuria classified into transient proteinuria seen in heavy exercise and albumin infusion. Orthostatic one seen in 2 to 5% of adolescents. Overflow proteinuria seen in hemoglobinuria, myoglobinuria, and multiple myeloma. Glomerular proteinuria seen in APGN and RPGN, and transient tubulointerstitial proteinuria seen in heavy metal intoxication and autoimmune diseases. This is about proteinuria. Proteinuria is done. And then we have nephritic syndrome, 3 causes already completed. Acute nephritis completed in 5 marks. Microalbuminuria, and what are the 3 causes of it? More than 30 mg and less than 300 mg. Albumin excretion is called microalbuminuria. Now, what are the 3 important causes of microalbuminuria? That is diabetes mellitus, essential hypertension, and also we have diabetes mellitus, and then essential hypertension, and in case of atherosclerotic diseases like coronary artery disease. So microalbuminuria is excretion of albumin for more than 30 milligram and less than 300 milligram per day. See, the 3 examples are diabetes mellitus, essential hypertension, and atherosclerosis. One of the causes is coronary artery disease. Bilateral pitting edema causes can be renal bilateral pitting edema causes. The differentiation between pitting and non-pitting edema. The pitting edema is seen when there is increased water content in the extracellular space. There is increased protein content in extracellular space. It will be non-pitting edema, like seen in case of filariasis. So, increase in water content in extracellular space, it can be right heart failure, it can be, and also it can be other disease. This about bilateral pitting edema. Non-pitting edema, 3 causes. Non-pitting edema, one of the causes is filariasis, and other causes thyroid filariasis, hypothyroidism. Other cause, it can be due to urinary tract infection. We already discussed all the causes. Can be urethritis, prostatitis. Also, it can be secondary to gonorrhea or chlamydia infection. Any 3 causes you can mention. What are the causes of polyuria? Polyuria causes are diabetic insipidus, which can be nephrogenic diabetic insipidus, and central diabetes insipidus. Also, we have syndrome of inappropriate secretion of SIADH, aldosterone, sorry, antidiuretic hormone, SIADH, which is the central cause of diabetic insipidus. And then polycystic kidney disease already discussed, renovascular discussed, acute renal failure discussed, criteria discussed, acute tubular necrosis discussed, CKD discussed, renal osteodystrophy discussed, hemodialysis indications discussed, complications during dialysis discussed, peritoneal dialysis discussed, contraindication of renal transplantation. Okay, contraindication of renal transplantation is medial calcification, contraindication. Absolute contraindications are active malignancy, active vasculitis, anti-GBM disease, severe disease, severe occlusive iliac disease, persistent substance abuse, severe mental retardation, severe psychiatric disease. You can mention any 2 to 3 causes. You will remember active malignancy, active vasculitis, and severe ischemic heart disease. Relative contraindications are very young patient, less than 1 year, older patient, more than 75 years, high risk of disease recurring in transplant kidney, like there are some glomerular diseases like membranous nephropathy or FSGS and other diseases which tend to recur in transplanted kidney. In that, prefer this. We have severe bladder or urethral abnormality is a relative SC, relative contraindications. This is about contraindications of renal transplantation. Urinary tract infection, we discussed. Urethral syndrome,